moment, there's a lot of confusion about what to do with pediatric LVO. There is an increasing trend to use both IV thrombolysis and mechanical thrombectomy in children. But whenever a case comes up, there's always a degree of delay, a degree of confusion. As this is really a result of the limitations on the guidelines and the current evidence base. And this leads to a lot, particularly patients who are in, say, peripheral hospitals. Doctors are not aware that thrombectomy could be considered or that things need to be rushed. And so this leads to significant delays. And so this is really a result of there being no real comparative evidence in the literature. There's been a lot of retrospective cohort work, some very good studies like the Save Child study, but all of this was kind of one-arm studies rather than having any control arm. And unfortunately, a randomized trials, they tried to do one for IV thrombolysis in children, but it failed. They had to abandon it due to a lack of recruitment and it lost funding. So the other problem with doing a randomized trial is that we have so much strong evidence in adults that it would actually be quite unethical to try and run a randomized trial in children, because if I had 2 8-year-olds in front of me, I couldn't realistically randomize one child to receive thrombectomy and one child to receive conservative management, and no parent would ever agree to partake in such a trial, I don't think. So that's where the problem lies at the moment in the evidence base. We essentially took 5 centres across Canada and New South Wales, Australia, who offer mechanical thrombectomy, pediatric stroke. And we took the stroke databases from all 5 and collated the data over the previous years, 2010 to 2022, and split them into cases and controls, the cases being those that received thrombectomy and the controls, patients who received conservative management or best medical therapy. And then we sat as a group of 5 people across the hospitals and as a committee and matched the cases with the controls using a hierarchical system, including the site of occlusion, the age, the sex of the patients, and the site of the occlusion. And essentially that allowed us to match the cases and controls very well. And a lot of the previous work that's been published didn't have any matching. So it tended to include a lot of adolescents with thrombectomy and a lot of younger children with conservative treatment traditionally. So this matched them. And what we ended up with was 2 groups of 26 patients each. The thrombectomy group had 28 procedures, and they were extremely well matched for age, for sex, for site and site of occlusion, the baseline aspects, for time of presentation. So as well matched as you could hope for in a randomized trial. And ultimately what we found was that if you looked at these patients 3 months down the track and at the final available checkup using the pediatric modified Rankin scale score, then the patients who had thrombectomy had significantly better outcomes and were much more likely to have a good functional outcome, both in the medium term and the long term. Hopefully we'll get this study published in a decent journal in the coming months. And once it's published, I hope to be able to use it to push the current guideline writers, both in Australia, in Europe, and in America, to revise the guidelines, because the existing guidelines for children, say in Australia, date back to 2017. The American Heart Association guidelines are 2019. So hopefully we would have enough with this study to say, look, we're unlikely to get stronger evidence. Therefore, let's go back to the guidelines now and write new versions. And while I can't tell them exactly what they should write, what I do feel is that we now have decent evidence in well-matched population that thrombectomy is of benefit, and therefore should kind of go from what is currently a weak recommendation to a true recommendation that this is something that should be offered. And I fear that if we don't update guidelines, there will be medical legal problems in the future, because one day a parent is going to say, well, why wasn't thrombectomy offered? There's enough evidence now that it should at least be discussed with all parents.